I'm Stephen Morrissey, Managing Editor of the New England Journal of Medicine, and I'm talking to Irwin Redlener, Director of the National Center for Disaster Preparedness at Columbia University's Mailman School of Public Health. Dr. Redlener has co-authored a perspective article on preparing health systems for disasters, such as the recent Hurricane Sandy. Dr. Redlener, in your article, you remark on how smoothly the evacuations of NYU's Langone Medical Center and Bellevue Hospital went. But you raise the question of why such extreme measures were necessary. What factors do you think were being weighed by the decision-makers, and in the end, was not evacuating those hospitals in advance a bad call?
Well, this is a complicated question. The evacuation of hospitals in particular, the nursing home evacuations, assisted living facilities have their own problems, but the evacuation of a large medical center with intensive care units and critically ill patients who are dependent on mechanical devices and electronic devices, they are extraordinarily fragile, and that's why they're in the hospital in the first place. The problem with evacuation decision-making is a complicated one because in order to safely evacuate, you need time, and the more time you have, the safer the evacuation it will be. So if you could evacuate 3 or 4 days before, let's say, landfall of a major hurricane, that gives you the best chance to move patients with deliberate speed, but also carefully and safely move them to another facility. If you have to evacuate during the evacuation itself, which is what happened with NYU Langone and then Bellevue immediately after, there are extraordinary risks to patients. The problem with the early evacuation, although it might be safer, is that sometimes the weather changes dramatically, the predictions, so that a storm that seemed to be headed our way directly all of a sudden has veered off in another direction. And I think at least 50% of the time, the predictions for landfall for a hurricane tend to be inaccurate. So patients might be put at risk for an event if they're evacuated for an event that actually doesn't occur. Hospital officials are obviously acutely aware of that, and nobody wants high-risk, fragile patients to be at extra risk because we're moving them in advance of the storm. So it's actually an ethical and medical dilemma to make that decision. In the case of the hospitals that happen to be in Zone A, which is the flood-prone area of New York City, a decision was made to allow the hospitals to decide for themselves, in essence, whether they wanted to evacuate or, alternatively, so-called shelter in place. And here's where we start getting into problems, because the hospitals are thinking, well, we'll keep our patients in the hospital, but we'll be prepared enough so that we could withstand the disaster. And that is dependent on a number of systems functioning very smoothly and functioning as predicted and desired. In the case of the electrical systems, which are obviously critical to the functioning of the hospital, after the experiences from Katrina, where hospitals' backup generator systems failed during flooding because they were in the basement and they got basically shorted out and they didn't operate, other hospitals around the country, including in New York, saw that experience and said, okay, well, we understand, now we're going to move our generators to a safe place high on a high hospital floor or on the roof. What they didn't do, though, was make sure that the electrical equipment, which had to drive the fuel for the generators from the basement or first floor up to where the generators actually were, that those fuel pumps and electrical switches weren't themselves vulnerable. So the decision made by the hospitals to shelter in place was based on a premise that turned out not to be true, i.e. that the backup power generation would be safe and secure. It turns out it wasn't. It was highly vulnerable. And that piece of misinformation was the cause of having to affect a very dangerous evacuation, although there was no harm done because of the heroism and skill of the evacuators. The problem is still that we put a lot of patients at peril, all because of faulty information regarding the stability and resiliency of the electrical equipment and the fuel pumps.
And in addition, when major medical centers are incapacitated, the stress on other facilities may be extreme. In fact, you note that at other New York hospitals, and especially their emergency departments, that kind of stress is still evident. The New York Times has reported that both Beth Israel and New York Presbyterian are overwhelmed. Do you have any sense of how much that reflects the normal volume of their emergency rooms plus the normal volume from the closed hospitals, and how much it's new illnesses and injuries that are actually related to the storm and the aftermath of the storm?
In terms of the consequences for the healthcare system and hospital systems in general, when you have to close major medical centers, there's a background that's actually important here, which is that over the last decade or so, there has been a tightening of the bed capacity in places like New York City because of cost issues. So having excess beds in general has not been a trend that's been supported, and in fact the opposite's true. So New York City, even over the last 10 years, has lost at least a couple of major hospital facilities, so that even before Sandy hit, we had a problem with the system's capacity, ambulatory capacity, as well as emergency department capacity, really being squeezed. And so when Sandy hit, there was not a tremendous amount of surge availability in the rest of the hospitals that were still functioning after NYU Langone and Bellevue closed, so that we have had and will continue to have for the foreseeable future, at least until those other facilities are open, increased pressure on the hospitals that remained to provide the outpatient services for people getting, being followed up for chronic illnesses and so forth, but also the emergency departments. Bellevue and NYU had extremely busy emergency departments which are no longer functioning, so that the stress on the rest of the system, on the hospitals that remained open, is very, very substantial, which of course ends up affecting quality of care, wait times, and all sorts of other issues which become evident when we have a prolonged situation of overcrowded hospitals.
Has there been an increase in illnesses, for example, psychiatric illnesses, as you suggested there might be after the storm?
Some of this data about specifically what the stress points have resulted in terms of increased illness, say, among people with increased exacerbation of people with chronic illness, or a bigger increase in the psychiatric problems that might come to an emergency room. That data is not available yet, and we're expecting it will be soon. We're still concerned that might be the case. We just don't have the information at hand right now to say definitively that is true or not. But the fact is that the stress and pressure on people who have been affected by the storm has been substantial. This comes anecdotally from healthcare workers and healthcare teams that we have in the field even now.
So what can be done to prepare hospitals for the kind of extended overload that Beth Israel and New York Presbyterian are seeing today?
One of the things that has not really gotten a lot of focus in New York City, and I think in other cities around the country, is the ambulatory and emergency department stress that is felt from hospitals that have become disabled for whatever reason. There has been much more attention focused on the inpatient side of the hospital functionality in terms of, if there was a big pandemic or other kind of major public health calamity, that there has been thinking about how to develop enough surge capacity to accommodate at least a good part of the demand from those kinds of circumstances. But there has been relatively very little thinking about what that means for the ambulatory services, and I think this is something that people are now waking up to, and unfortunately, I don't think there's been a lot of far-ranging thinking about how to accommodate big surges in ambulatory capacity or emergency department capacity in the aftermath of a disaster. In fact, when St. Vincent's Hospital, a hospital in the lower part of Manhattan, was closed a couple of years ago, it was closed rather abruptly without really any substantial planning for how the remaining hospitals would accommodate what had been a large emergency department volume happening in St. Vincent's. But and so the hospitals really struggled to accommodate. But this was also an acute closure of very major medical centers, and with really very little warning in terms of what needed to happen in the ambulatory division. I don't think that's sorted out yet, and there certainly is no plan for how that's going to get better in the future or for future disasters. It's on the to-do list, so to speak, for officials here in New York.
And as regards the evacuated hospitals, do you know the status of the buildings there and whether and when they'll be reopening?
As you can imagine, decisions about the reopening of hospitals that were shut during the emergency is a very complicated one. It's really obviously not a medical question. It's a question of a very careful engineering and structural analysis of those facilities and the systems within those facilities and when they can be back up and running. There's all sorts of estimates flying around that range from several months to maybe much, much longer than that. And I think we'll know more about this after the first of the year, but very intense analysis of the physical needs and infrastructural needs in those hospitals is already taking place. And by the way, it should be noted there's going to be a tremendous cost incurred by the repair and rebuilding of infrastructure in those hospitals. So it's really hard to say, but issues of like mold or getting the electrical system back online and determining and making sure there was not any kind of structural weakness that occurred as a result of the soaking storm and storm surge.
And how about New Jersey, which was very hard hit too? How well were the healthcare institutions there prepared for this storm, and how's the state recovering?
New Jersey is doing actually reasonably well. There are some issues in New Jersey about where people are going to be sheltered for the long term. This is pertaining to people who were in communities that have been really quite destroyed and are going to now have to be individuals and families needing to be displaced for very long periods of time. So they're still working on how that's going to be accommodated by a healthcare system that's going to have to make sure that the people who have chronic medical illnesses or develop acute surgical or medical situations, how and where they're going to get their health care is something that is really in play right now. But generally speaking, New Jersey is a pretty proactive healthcare infrastructure on the public side, and I think they're doing reasonably well right now.
Another recent Perspective article focused on the effect of storms on non-hospitalized populations with functional needs, people who depend on home nursing, on personal care attendants, on medical technology that requires electricity. What happened to New York and New Jersey residents with functional needs of that order, and what kinds of steps are being taken to ensure that they'll be safe the next time something like this happens?
One of the biggest problems that we rapidly became aware of were, in fact, those populations who were not in the hospital or not in a facility of some sort. There are the hundreds of thousands of New Yorkers or New Jersey residents who were living on their own, or either homebound individuals with people with disabilities or chronic medical conditions that were highly dependent on services being delivered to them or going out for ambulatory services. It also included just frail elderly people living on high floors in tall elevator buildings who had to sustain lots of problems during a time when the electricity was off, the elevators weren't running, communication was down, and they couldn't even communicate their needs. So I think one of the things that we're very concerned about, and that the piece in the New England Journal by Jan and Lurie pointed out very strongly, was that we're going to have to develop systems that are much more robust in two aspects. One is, how do we identify? Do we need registries, or what do we need to make sure that we know where these vulnerable people are who are not in hospitals? And secondly, what exactly are the systems that need to be in place to make sure that those individuals are protected and cared for at time of great need? And to me, I must say, sort of as a side note, that really the success of our responding to a major disaster, as far as I'm concerned, can be measured in terms of how well we do in protecting and caring for the most vulnerable individuals. And those people who are already resilient before and during the storm, who are healthy and active and young and can deal with stress, will certainly have needs. But it's really in some ways far less stressful, traumatic, and difficult than an 85-year-old person who's got some disabilities living on the top floor of a building that requires an elevator. It's a whole different agenda, but one that we really do have to pay attention to, because they will really need organization and planning before, and highly effective, efficient services delivered in a structured way in the aftermath.
You say, too, in your article that we need to do a better job applying lessons from past disasters. Were there lessons from Hurricane Katrina, for example, that were not applied in this case?
I can't quite think of any problem or challenge that we had in New York City, for instance, as a result of Hurricane Sandy, that was not forewarned by challenges and problems they had in New Orleans after Hurricane Katrina. But unfortunately, we don't do well in learning the lessons from previous disasters. Either we don't learn the lessons, or we structure responses that may have fit some specific challenge that we saw in the last disaster, but doesn't really apply to what we're seeing in the next disaster. So I think one of the great difficulties in, let's call it the science of disaster planning and disaster response, is that much of what we do and much of how we plan is not in any way evidence-based. We end up planning through anecdote or personal feelings or other kinds of processes, which leave us to repeat the mistakes of the past. It's really quite unfortunate. And this one of the antidotes to that is having a lot more academic centers that have been actually focused on doing research that matters, is what I would say here. And for instance, the decisions about sheltering in place or evacuating hospital populations and nursing home and assisted living populations, the commissioner of the state health commissioner for New York, Nirav Shah, pointed out that quite rightly that there were some studies done after Katrina which showed high fatality rates of evacuated elderly people or frail people from nursing homes in New Orleans, but that these fatalities did not occur immediately, but they did occur and were statistically significant 90 or 120 days later. And that becomes a factor then in deciding whether we're going to try to evacuate or try to stay sheltering in place. So I think what I'd say about that is we have to pay a lot more attention to making sure we've learned and applied the lessons of the past, and making sure that we've done and we're doing the science and the research to better inform disaster policymaking going forward.
And what, to your mind, are the most critical preventive interventions that we should be looking at?
Well, among the things that we should be looking at going forward is, number one, would be a lot more robust monitoring of the state of preparedness and the resiliency of critical systems in hospitals. And, of course, the key example here is the backup power generation systems, so that we've not only tested the generator itself, but we have serious experts review the entire process from top to bottom. So where's the fuel coming from? How does the fuel get from wherever it's stored to the generators? What is the supply chain of the fuel? What are the electrical systems within the hospital to make sure that pumping occurs and so forth? And are all of those basically made as resilient as possible to whatever conditions we might have. So, and who's going to expect that? There should be a much more rigorous, robust certification processes to make sure that hospitals are, in fact, able to shelter in place and that the appropriate steps and monitoring has actually taken place. And the second thing is that, as we were talking about before, the need to understand where the most vulnerable people are that are not in hospitals and in the healthcare facilities, but are in the communities. Where are they? Who are they? What do they need? And how we're going to make sure their needs get met is, to me, one of the most important challenges we face as we look to make us more disaster ready for the future.
Thank you, Dr. Redlener.